All right, we've got some more people walking in the door just in time. For those of you, again, who have not met me, my name is Ken Crossan with Piedmont Injury Law. We're a personal injury law firm currently in Marietta, although moving to downtown Kennesaw early next year. And we've started this series of a bunch of related events under this banner of raising the bar. The idea being to bring together everybody who works in the personal injury space, people who work in a variety of different capacities with our clients, who, by working together and by educating each other and by increasing our communication and our deepening our relationships with each other, will allow us to achieve better outcomes for that population of people that we all serve in our businesses. So these events, we've been doing them for about a year now. Every other month, we've been putting on these educational lunch and learns. Obviously, we got thrown a little bit for a loop this year when the world melted down around February and March. But we've carried on having these events virtually. And the last couple of events, I think I mentioned, we've started having these hybrid events where we've got some people in the room. Actually got a nice group of people in the room here, and also some decent attendance online. So we'll check one more time to see if there's anyone in the waiting room, and looks like we've got everybody on board. But as the kind of the name of the initiative and the nature of the events implies, our mission is to raise the bar within the personal injury industry to achieve the best possible outcomes for our clients, our current clients, and our future clients. Everybody in this room and everybody online, I know and appreciate you for wanting to improve your practices, improve the ability to serve the communities that we serve, and to help us, lift all ships and raise that bar so that every year we're doing better and better, and our clients are getting better and better outcomes. To that end, this month, our speaker is Dr. Chris Connelly. I'm sure many of you know him personally, and many of you also know him by reputation. He is chiropractor in Stone Mountain, although he does get around a bit. He's been in private chiropractic practice for 23 years. He is certified in the 5th and 6th edition of the American Medical Association's Guide to the Evaluation of Permanent Impairment, which will be pretty much his topic today. He also utilizes brain scope for concussion testing, DMX or functional X-ray for joint functioning, and All-Core 360 for deep core spinal strengthening. He's one of approximately 15 providers in the state accepted as a review agent. He testifies in court and has on many occasions been utilized as an expert witness. Dr. Connelly is an American Chiropractic Association delegate to Georgia, and he served on the Attorney General's anti-opioid task force for Georgia. He was the 2019 GCA Chiropractor of the Year, 2019, that was last year, and is a founding member of the Academy of Georgia Chiropractors. He currently has 3 15-hour seminars that he will present next year on impairment rating, concussion, and facet injury. And just kind of on a personal note, I'll tell you that every time I've sat down with Chris Connelly and discussed personal injury issues with him, the only thing I've wished when it ended was that we had had more time. Because I could sit down and listen to this guy talk for as long as he's willing to talk to me. He's such a font of information and such a great resource. So without any further delay or further ado, I'm going to introduce you all to Dr. Chris Connelly.
Well, thank you, Ken, and thank you for having me. Can you guys hear me okay?
We can all hear you here.
Perfect, great. So as Ken said, I am one of the founding members of the Academy of Georgia Chiropractors, and this is the beginning slide where it talks about how to join and also what we encompass, which is evidence-based practice, education, benefits, and relationships with other providers. The big thing at this point in time is the benefit services with our health insurance. So anyone is interested in learning more about the Academy can go to academydoctors.com. And, as Ken said, he went over a lot of the different things that I do. And I've been in practice 23 years. We've seen over 15,000 traumatic auto injury patients. I've also been an expert witness in reviewed files approximately 2,000 times over my 23 years. And I've been in court, depositions. About 50% of the time I've been a plaintiff expert and 50% defense expert when it comes to testifying in court or depositions. I'm certified in sports chiropractic and concussion protocols and training. Next year, I'm going to have a seminar on concussion for chiropractors, and it's basically going to outline the different types of concussions. Also, I'm going to have a 15-hour seminar on impairment ratings, basically to hold providers' hand on how to do impairment ratings. I currently do about between 2 to 5 impairment ratings a week, and you see very significant pathology. And then also I'm going to have one on Facet syndrome. So next year, we'll also have seminars on Facet syndrome. This is going to sort of be a little combination of impairment rating and Facet pathology. So if you like the things that we talk about today, then you could go to injuryuniversity.com, and that's where we're going to have how to get those 3 different types of seminars: the brain injury, concussion, and Facet syndrome. As Ken said, I am certified in the fifth edition, the AMA Guides to Impairment Rating 5th edition, and the 6th edition. I'm one of only a handful of providers in the state, medical or chiropractic, that are certified in both the 5th and 6th edition. So when you're talking about impairment ratings, there's some text that you should really get and some things that make your life a lot easier. Because one thing to think about impairment ratings, it's not really an opinion. It's that you're following the guides as closely as possible. And so the purple one's the 6th edition, the green one's the 5th edition. This is one I like. It's called the AMA Guide to Evaluation of Disease and Injury Causation. So many times when I'm an expert in court or even evaluating a patient for apportionment or different attributes of a more serious injury, I use this one, and the AMA Guides to Disability Evaluation. So these are the 4 principal texts that I'll refer to very commonly. Another one are the ODG guidelines, the Official Disability Guidelines, and I'm certified by the Official Disability Guidelines as well. And they're evidence-based guidelines on everything from chiropractic to biofreeze to injections, MRIs, things like that. So it's a good evidence-based system. So there's 6 editions, and the AMA Guides, just a historical context, started back in 1958. And when it started in 1958, it was basically just in the AMA Guides that they would have articles, and they would just submit articles about different topics and about impairment and different conditions. And over the years, they've been consolidated. So those articles were consolidated into chapters. So the 5th edition was something that, was really cool, that all the chapters were very unique and very, very related to the topic or the diagnosis. But the 6th edition I like much better because of the fact it actually winds up, the methodology and the way that you give the impairment is the same regardless of the clinical pathology. So even if someone has like a pneumothorax or loss of vision or things that we don't diagnose in our clinical practice, any provider can actually use the guidelines to give an impairment rating. So even if I'm giving an impairment rating on a serious pathology, like say a heart condition or pneumothorax or amputation, things that aren't in our scope of practice, as long as it's diagnosed by the proper medical specialist, you could take that diagnosis and apply them to the guidelines to be able to do your report. So the cool thing about impairment ratings is that it's not really a diagnosis. It's more or less a summary of the diagnosis to apply them to the guidelines to give a percentage rating. So the 5th edition was very liberal. So very few people will get them, but the ratings tend to be really high. And there was a lot of inter-rater error. So a lot of times one provider will look at it and get 15%, another one get 12%, another 20%. So with the 6th edition, they made it much more uniform and much more logical. And they found lower ratings, but more people qualify for them, but also more consistency among providers. And I would say one of the biggest things to take away from this seminar when you're doing impairment ratings is show your work. So one little pro tip that I use that I would like to tell everyone about is if you go on Amazon and buy the book on the Kindle, whenever you're doing your report, you just copy and paste, or you cut the actual charts and put those into your reports. When I'm doing depositions or if I'm doing reports, I love to have the actual reports with me. I've done depositions where they'll actually say, Dr. Connelly, can you walk me through how you came up with this rating? And I'm able to do a PowerPoint presentation or actually open the book and show them how I came up with the rating. So it's very powerful to put into the reports. But like I said, if you go to Amazon, buy the Kindle version, you can literally just cut and paste and put those into your reports. One thing that's really cool about the AMA Guides, they say this in the 5th and 6th edition, is that chiropractors are specifically named that they're able to do impairment ratings. Like I said, I've been an expert for plaintiff and defense in giving opinions concerning impairment ratings, and it is very valid that chiropractors are perfectly able to do impairment ratings. So this is the chapter and the page in the AMA Guides that says chiropractors are able to do impairment ratings. It also says non-physician evaluators may analyze the impairment evaluation to determine if it was performed according to the guides. So this is a really important thing for us because many times chiropractors sort of get pushed under and saying, oh, you can't do this, you can't do this. But in the AMA Guides 5th and 6th edition, it specifically says chiropractors are perfectly able to do impairment ratings. So these are like 3 big takeaways from impairment. You have to follow the procedures outlined in the guides as strictly as possible. Any variations or circumstances should be explained in detail. So theoretically, everything's pretty straightforward, but there's always complications. It could be pre-existing, it could be maybe non-compliance with treatment. So there's lots of different things that may need to be detailed. So follow the guidelines as strictly as possible. And then also if there's any deviation from the guidelines or special circumstances, it's always important to outline them. One example is that it does say in the guidelines that if you aren't able to get surgery, but you have a condition that would qualify if you did get surgery and have a valid surgery need, but don't get it, you could still give the impairment rating as if they already had the surgery. So those are things that you'd have to explain the special circumstances why they didn't have it. And the reports for the impairment rating should be detailed as possible. Because again, other medical professionals, chiropractors, or even non-medical can look at the guidelines and then apply them to the textbook. So they could open up the textbook and see where you got it from. And the goal is an accurate, unbiased assessment of the impairment rating. It's actually better if a non-treating physician does the impairment rating. So it specifically says in there that treating providers can do the ratings, but it is better if unbiased can. In many cases, people come in for an impairment rating and they don't qualify. We also do them not just for auto injury, we also do them for the VA. We also do them for people who just walk in off the street if they want to have an impairment rating. And about half of them don't qualify. So it's very common for people to come in and we'll do a review and it turns out, well, you don't really have an impairment. And they may say, well, doc, I can't work, but that's disability. Impairment's what's wrong. And we have to have some type of documentation what's wrong. Now, sometimes we could guide them in the right path and say, look, it looks like you have a herniated disc. Go see, go get an MRI. We could start seeing you for treatment or refer you to a provider for your condition. But without a valid diagnosis, the impairment rating can't go forward. So the goal is an accurate, unbiased assessment of impairment. Impairment is the first step for determining disability. So if someone cannot work, why can't they work? I can't work because my back hurts. Well, pain is not a valid diagnosis unless there's certain other circumstances. You need to have a more specific diagnosis. So some type of anatomical diagnosis, particularly to tissue damage. So of course, amputation in the spine, it could be facet, it could be nerve, it could be disc. So you have to have some valid diagnosis. And ultimately, when you're doing impairment ratings in any aspect of dealing with injury claims or whatever you're dealing with, it's important to recognize that if this goes to a jury, they ultimately determine what's reasonable, what's not reasonable. So it's really important to do things correct the first time. That way, later on, if you do have to defend your reports or you have to do different things in a court setting, that the jury perceives it as credible. Because if it's not usual, if it's not reasonable, it's not customary or necessary, the jury is going to see through that. So it's important to follow the guidelines as best as possible. So we use the usual, reasonable, customary, necessary for all aspects of a claim. So it could be the diagnosis, the testing, the treatment, the billing and coding, the disability, and the impairment. So if there's no diagnosis, then the billing or the coding may not be important. So it's really important to make sure all your documentation is based on, is it usual, reasonable, customary, and is it necessary, particularly related to the collision. So in the field of personal injury, this is a great reference. So this is Trial Guides. If you guys don't know what Trial Guides is, it's a wonderful education platform for trial attorneys, but also medical doctors and chiropractors. And this is a book called Understanding Jury Bias. And it is important when you're testifying and you're defending these opinions to be, again, not an advocate, just to be a recorder of fact. And if you're an advocate, that's going to really come across poorly anyway. So it's important to really be a voice of reason when you're going to court, not that you're an advocate for one side or the other side. And this book talks about jury biases, and then juries do have a bias when they're dealing with these type of claims. And it's also stated in the AMA Guides, which the AMA Guides 5th edition say up to 85% of people who report back pain have no pain-producing pathology that can be identified. There's no demonstrable tissue pathology. So in the end, a lot of these people get classified as malingering. I don't know what's wrong, but in many cases, it's the provider's fault for not accurately doing a good diagnosis to find out what the tissue pathology is. I routinely see patients who come in, no one could find out what's wrong with me. And we do a good, complete evaluation and find out the anatomical diagnosis. I had one 2 weeks ago where the orthopedic referred, and they typically do surgeries and injections and things. And they're like, I don't know what's wrong with you, but go see Chris. And when the patient came in, it turned out they had anterior scalene syndrome. That was causing a lot of the problems. So a good diagnosis is the first step to a great treatment, but also it's really important in the injury claim that if you can't tell what the tissue damage is, then the jury is going to automatically feel that it's not anything that's credible. So if someone says to the jury they have back pain and that's why they're having all these problems and they can't work and they're going to have pain for the rest of their life, the jury's going to say, okay, well, I don't know if I believe that. If you say it turns out that they had a fracture, they had a disc herniation, some type of anatomical pathology that is relatable to a trauma, the jury will go ahead and say, okay, that seems reasonable. Because also in the AMA guides, it talks about this, and this is a very credible and I think accurate statement. To have great pain is certain. To hear that another person has pain is doubtful. So many times if someone says, that person has pain, oh, I'm sorry to hear that, but it's doubtful. It can be that bad or different other things. When you have pain, it's certain, you know it. So it's really important with patients to really find out the anatomical cause of pain, because when you're going in front of a jury, this is the philosophy that they have, is to have great pain is certain. So if they've had pain, they go, oh, I know what it's like. If they haven't had that pain before, then a lot of times they're very doubtful as far as the patient's condition. So it's really important to have a good anatomical diagnosis. And again, the anatomical diagnosis is very important for the impairment rating. So what is an impairment? So there's two definitions I like. One is from the AMA Guides and the other one is the Social Security Administration. So the AMA Guides 6th edition says, an impairment is a significant deviation, loss, or loss of use of any body structure or function in an individual with a health condition, disorder, or disease. I actually prefer the Social Security Administration definition a little bit better. So the Social Security definition says an anatomical, physiological, or psychological abnormality that can be shown by medical acceptable clinical or laboratory diagnostic techniques. Now, both are ultimately saying the same thing, but I think that from a provider standpoint, the second one gives us a little bit more guidance on what an impairment is. It's basically what's exactly wrong that they're having continued pain or problems. So whenever you're dealing with a claim with someone has continued pain past normal healing, you say, what's the diagnosis? What's wrong or what's causing the symptoms? What's the tissue damage? Causation, how likely was this caused by the event? Of course, if they have pain before or have a problem before, a collision can aggravate it, exacerbate it, or cause new damage, but it's important to differentiate that. Apportionment, how much of the problem was caused by the traumatic event and how much was pre-existing? Permanent impairment, a medically diagnosable objective condition related to the event. So remember, with a jury, we want as much objective evidence as possible to be able to show what's wrong with them and what type of tissue damage could have been related to the problem. So if someone does have a condition, let's say a heart condition, and they get into a car accident, how likely is that to be attributable to a car accident? Well, not very likely. So the diagnosis also has to be something that is commonly associated with an auto collision. And disability, what are the functional difficulties caused by the tissue injury, tissue damage, or impairment? So disability and impairment are completely different. Many times they're used interchangeably. Impairment is what's actually wrong, the actual diagnosis. Disability is how that impairment is affecting their life, and that could be vastly different. Now, many times when we're dealing with these type of claims, we're automatically going to the MRI, and we basically say, okay, you have pain, get the MRI. And it's important to recognize that, one, that's sometimes not needed or not appropriate, but also it's important to learn how to read the films yourself, look at the films, do clinical correlation with the patient's symptoms, with the clinical findings, with your physical findings. It's important. That's one piece of the puzzle, but that's not the entire puzzle. Particularly because this is a great study that was done where they had one patient, 10 MRIs in a 3-week period, and she went to 10 different facilities and they had 10 different results. This is the same patient. These were not auto injury cases. These were just regular patients, a regular patient that went to 10 different facilities. There were 49 unique findings, 49 different findings. 16 of those were unique and 0 across all 10. So there's no radiologist that agreed on all of the findings. Each radiologist averaged 12 errors. So don't always rely on the MRI report. It's really important to have them read it from a medical standpoint for any type of cancer, tumors, any type of pathology that may be something that's more serious. but it's really important to craft your skill in reading MRIs to be able to correlate those with the patient's symptoms. I've seen where patients have significant findings on MRI at one area, but actually the pain was coming from a different area. So it's important to use this as a tool, but also not a standalone tool. It's part of your clinical toolbox to be able to give the patient the best diagnosis possible. It's also important to recognize that most people have bulging disc and herniated disc. This is in the Journal of Neuroradiology. And so even into their 20s, people had disc degeneration, signal loss, disc bulging, protrusion, annular fissures, facet degeneration, and spondylolisthesis. So if you look, this gives a good idea as far as the prevalence of pathology at certain ages of life. Obviously, when they get older, they're going to have more degeneration, more bone spurs, more pathology. An important thing to recognize here is that annular fissure is often used interchangeably as an annular tear. So an annular fissure could be completely normal. And so sometimes they actually will use the term tear, which a lot of the standard rating guidelines say you shouldn't use tear because it makes it seem like it's an acute pathology. But a fissure is actually a normal degenerative process that can occur, but could be a finding, but not necessarily a tear. And so that's something really important that sometimes if you see in an MRI report, it could say it's a tear when actually it's a fissure. So again, you want to have clinical correlation with the symptoms and also the history of the findings as well. The same thing is true in the cervical spine. So they did a study of 1,200 people with no pain, and they found even people in their 20s still had bulging disc in their neck. So it is important to recognize that some of these findings could be completely normal and incidental. And so it's important to talk to the patient about what's actually causing their pain, not just go by the MRI findings. It's interesting, in this one, they did find that signal intensity was an indication of more acute pathology. So if you have hydration in there and you see the migration of the disc, that's something that's a little bit more correlation with acute pathology. And so if you look at those, you'll actually find those. And I like to take pictures and put those into the report as well, because those are signs of definite acute pathology. And again, study this a little bit further, but there are things you can look on MRI to be able to see what's acute pathology and what is more chronic in nature. And the same thing is true for the knees, shoulders. You know, you see many type of incidental findings or abnormalities in people with no pain at all. So just because they have a tear in their shoulder doesn't mean it was from the collision. You want to go ahead and also do some other things to look at some type of pathology that maybe more highly related to an acute trauma. So a full thickness tear is much more likely to be due to an acute pathology than if it's a partial thickness tear. So anytime I see full thickness tear, I always think it's more likely to acute pathology. And it was most likely a partial thickness tear, then the trauma occurred and they made it into a full thickness tear. So again, there's certain things you want to look at to see what are things more closely related to an acute trauma and what are things that are just normal and even in the asymptomatic population. And these are things that are horrible to see in records. So they give no credibility, and particularly from a radiologist, you know, you'll see that they say, oh, you know, this bulging disc or herniated disc, medically probable that these are related to the patient's accident data this particular day. Well, how do they know that? I mean, and so, you know, radiologists should not give opinions concerning causation, because how do they know that this is something related to a particular thing? They should just report on the findings. And so this actually damages the case and leads to credibility issues. And so I've actually seen it before where I was a defense witness and the MRI was done 2 years after the collision, but they say this is more likely due to acute pathology from a collision, but yet the collision was 2 years removed. So this really does hurt case more than it does help the case. And oftentimes too, you'll look at the arrows and you'll say, man, this is pointing to something that's relatively normal. I don't see what they're talking about. So overreads just hurt cases, and also later on could cause problems, because when they do go to court and they have an expert to look at this, it's going to decrease the credibility. And any speculation of impropriety or problems with the jury is always going to turn out negative, because the jury does have a bias. So our early MRI findings correlated with long-lasting symptoms. And this was a great study done in the European Spine Journal. And they found that MRI is not the answer to a diagnosis in the vast majority of patients that develop long-lasting pain after whiplash injury. An early MRI scan does not predict prognosis. It may be relevant to focus future trials on imaging of the upper cervical spine, including functional imaging. And that's what we're going to talk a little bit about today as we do something called motion x-ray or functional x-ray. And that, along with clinical examination, helps us to determine some of the things that you may see in the spine. But many times, the accident happens and, within immediate MRI happens and they find incidental pathology and they may get epidurals. And then they come to me years later and they say, well, I had this epidural. They said I have a disc bulge. And I'm like, well, the pain was coming from the facet or torn ligaments. It wasn't actually coming from the disc. And so they just got the wrong treatment. So it's really important to clinically correlate all the findings, but also for a vast majority of patients, early MRI without radicular symptoms did not have any influence on the long-term prognosis of patients in 1-year follow-up. So it's really important. MRI sometimes is needed, but it's also important just not to scan everybody because you're going to find that a lot of incidental findings. And with those incidental findings, sometimes that could lead to a wrong path of treatment. So this is a pretty cool statistic. And how many joints are there in the spine? How many total joints are there in the spine? And there's 361 total joints in the spine. That's a lot of joints. Now, we're more familiar, though, with the synovial joints. So there's 97 synovial joints in the spine. That's still a lot of joints, especially when you figure a synovial joint has a capsule, has lots of nerves, has hyaline cartilage, very dense in nerves, also has usually a synovial fold that has a lot of nerves in it as well. So 97 joints in the spine are pretty significant. Now in the cervical spine, which again, we're talking more about today, the cervical spine has 17 synovial joints. There's still lots of joints and ligaments in there that can cause the tissue damage. So it's really important that maybe not just one of them is damaged. There could be multiple ones. So one thing I talk to a lot of providers about is they really don't have any clue how many joints there are on the spine. They just think we have 24 vertebrae. So as you can see, we have 97 synovial joints and we have 361 total joints in the spine. So as I stated earlier, we do something called functional x-ray or motion x-ray, and that helps to determine when, particularly in this case, gapping of the facet capsular ligaments. So today we're going to spend some time talking about the capsular ligaments. So during oblique flexion, you'll see the capsular, the facet joints move, and there's space in between there. The capsular ligaments hold that in place. Now, as the ligament winds up being maybe hypermobile or unstable or torn, you're going to see gapping of those facet capsular ligaments. And so typically I'll do an examination on the patient first, and we do axial loading with oblique flexion. And when they say, doc, man, it hurts right here, it hurts, and they point to where the facet joint is, then we'll do the motion x-ray, and I'll look particularly for the facet instability. During clinical examination, we also check the upper cervicals, we check lots of different things, and try and pinpoint where the radiographic functional x-ray needs to be taking place. Sometimes you'll see in providers, also the positioning makes a difference too. So it's really important to study functional x-ray to be able to know how the patient position, because I also see sometimes people do A to P open mouth and they'll learn to the side and the head will turn. When that turn, that magnifies and can distort the image. So whenever you're doing functional x-ray, it's always important to know a lot about patient positioning, because the wrong position can give the appearance of instabilities when it's not there. But in this particular case, you can see the gapping of the facet capsular ligament, and this is actually relatable in the AMA guides. So the AMA guides 5th edition says motion of the individual spinal segments cannot be evaluated by physical examination, but is evaluated by flexion, extension, radiography, x-rays. So this is specifically in the 5th edition where they talk about that you cannot do an accurate individual level spinal examination on physical examination. It has to be done by x-ray. And I wrote a paper, and anyone wants it, I'll give them a copy. It was actually published in the AMA, the American Journal of Pain Management. And I go over the different ligaments and also what are the key findings when you're looking at the different pathologies. There's a couple others that have been recently out, which are pretty cool. But, of course, we have lots of joints. We have lots of ligaments, alar ligaments, transverse ligaments, facet capsular ligaments, posterior longitudinal ligaments, anterior longitudinal ligaments, and interspinous ligaments. So again, interspinous ligament, ligamentum flavum, capsular ligaments, PLL, and ALL. So all these ligaments can be damaged, particularly in a car accident or a fall or sports injury. But in particular, the facet joint has been shown to be more likely cause of continued pain, and I'll explain why in a second. This is another article that just came out talking about video fluoroscopy. So DMX, video fluoroscopy, and functional x-ray are used interchangeably. So this talks about the reliability of it, and again, some of the key findings that you would want to see. Anyone who's interested in this, let me know. And also on the Academy, if you're a member, you get our listserv. And our listserv, we routinely will put out some of these articles. So if you are a member and not getting them, please make sure that you're on the listserv. And also, if you're not a member of the Academy, please join, and you'll get a lot of this information for free. This is the article that I published back in 2005, and it was the American Journal of Pain Management. It's a peer-reviewed medical journal talking about the facet joints as a definite diagnosis in most patients who have continued pain after car accidents. And this isn't just in my paper, but also other papers we're going to talk about in a second are now pointing that that's the #1 cause of continued pain in the cervical spine after motor vehicle collisions. So whenever we're looking at functional x-ray, we look at the bones, but we can't see the ligaments, but you can actually wind up seeing the functional systems that the ligaments would hold in place. So if you see too much translation posteriorly, that could be a problem with the anterior longitudinal ligament. You could also see too much extension. So there's different things you look at to be able to see the ligament, how they normally should function. If they're not functioning correctly, what are some of the pathologies that you may be able to relate to that? Again, you want to correlate it to the patient's symptoms and the physical findings. This is a great article in the journal Spine, which is one of the most credible spine journals in the world. And it goes over all the different types of pain after motor vehicle collisions. And zygapophyseal joint are the facet joints. And what they found is the facet joints are the only one that check all the boxes as a potential to be long-term causes of chronic pain related to motor vehicle collisions. Dorsal root ganglion, muscles, vertebrae, spinal segments, and disc lesions are farther down on the list. And so it meets all the qualifications as far as a pain generator, and also can lead to arthritis because abnormal function of the facet joints can cause wear and tear and problems. And again, the mechanism of injury. So there's multiple types of mechanisms, not just a whip and a lash, but it is something where there's multiple mechanisms of injury, but it does put a lot more stress on the facet capsular ligaments than any other type of ligament. And it is recognized by the AMA guides as a valid impairment. So this is a table, and you always want to go ahead and look for the table. And when you find the diagnosis, remember these are diagnosis related conditions. So you see facet joint pain, and then you go ahead and say, okay, they still have pain. They'll be considered a class 1. Whenever you're doing an impairment rating, you start off and it starts in the middle. So whatever it's 1 to 3, you start in the middle at 2. The cool thing about the 6th edition is it gives you some leeway as far as your functional capacity, as far as your pain, the clinical findings, the physical examination, to be able to go from one side to the next. So we have functional history, clinical examination, and clinical studies. So if it's not too severe, then it goes down to 1. And I'm going to show you the formula in a second. If it's very severe, then it could go to a 3. And this is universal for every pathology. So it could be a disc herniation that needs surgery, and then maybe 19%. And then if the patient recovered, still has some problems, but not too bad, it could be 15. If they may develop adjacent joint syndrome and may future need more surgery, that could be 23. So it allows you to fluctuate within this box depending on how the patient responded with their diagnosis. And I like this because of the fact it's much more specific to the patient's condition. This is a great journal, the Journal of Biomechanics. Facet capsular ligament yield a definite threshold of injury and persistent joint-mediated neck pain. And in there it talks about all different mechanisms on why the facet capsular ligament is under a lot more stress. But there's 2 factors that are really important. One is the multifidus muscle and the deep spinal stabilizing muscle in the cervical spine inserts directly into the capsular ligament. And that's important because about 23% of the capsule is the insertion for the muscle. So if you have some type of severe trauma, that muscle, when it pulls on that ligament, is going to pull really hard and could cause some ligament damage. Also, the jamming of the facet ligament and also the way that it holds a joint in place can cause it too. So if the head's turned during the collision, that could cause problems. And also if there's torsion or different forces, particularly shearing forces involved. The facet capsular ligament, just as most ligaments, have something called viscoelastic properties, meaning that they stretch like Play-Doh. So if you stretch it really nice and slow, it stretches really well. If you shear it or if you pull it really quickly, those ligaments can tear very easily. So facet capsular ligaments have viscoelastic properties, which often can lead to a mechanism of injury because of the fact that under slow loading, they could actually respond really well. If it's a quick, rapid shearing force, that could actually damage the ligaments in a different mechanism. And it's also important to recognize patients who have pre-existing arthritic conditions. Many times they say, oh, it's only degeneration, but they actually have a higher risk of injury. So again, this is an example of the synovial joint, the facet joint. You have the capsule, you have the synovial fluid, you have the hyaline cartilage, and there's a lot of nerves that go to that. So the nerves from above, that same level, and from below. So it's innervated by 3 different nerves to that area. So there's rich nerve innervation there. So when you tear those ligaments, that could cause a lot of pain and inflammation. If there's a bone spur, that could cause more damage. But again, if you look at the joint, the internal joint of the hyaline cartilage has a lot of inflammation and a lot of arthritis, that's something that could cause more pain. It's interesting, in a healthy joint that has normal hyaline cartilage and synovial fluid, the viscosity or the friction when they rub together are like 2 pieces of ice cube. That's how fluid the motion is. So when it moves together, it's going to absorb a lot more trauma because it's very viscous and has lots of good range of motion and less friction. If you take an arthritic joint, that could be thought of like 2 pieces of sandpaper rubbing together. And that could cause more inflammation, more joint damage, and more pain. So it's important. A lot of times people say, oh, don't talk about arthritis, or don't. It actually increases the risk of injury. And so it's important for the patient to talk about that, but also get this joint moving. The more you move the joint, the better it is for the synovial fluid and the hyaline cartilage. You want good range of motion to that joint to try and pump the fluid in and the good fluid in and bad fluid out. But range of motion helps the disc heal better too. This is a great study in the Journal of Arthritis and Cartilage. It showed degenerative facet capsular ligaments pose greater increased inflammatory and angiogenic factors or features, suggesting these roles may play a prognosis in facet joint degeneration and the neurostimulation of afferent pain fibers. So what they found is that the facet capsular ligament, if you have degeneration and signs of deterioration, it has more nerves there. When they have more nerves, they have a higher risk of injury. And so that's an important thing to note, is that the more nerves that are in the area, the more likely that they're going to have pain and inflammation. You're also going to see in this one, they talk about neuroplasticity of the sensor and parasympathetic nerve fibers. Now these are in joint mouse, but they found that there's more sensory nerves in an arthritic joint than a healthy joint. And that's why it takes less trauma to irritate these joints, and why it's important to affirm to the patient, it's okay, things are going to heal, the pain will go down, let's get you moving, let's get things calmed down a bit, because of the fact that they have higher risk of pain. Remember, pain is a physiological and psychological phenomenon where it occurs with the patient's perception of pain just as much as the true tissue damage as well. So obviously, the more nerves that are in the area, the more likely they're going to feel pain. And the association between cervical degeneration and self-perceived recovery and whiplash injury. So this is an interesting one. Again, this is the journal Spine. And what they found is that facet degeneration was a more prognostic indicator of long-term pain than disc degeneration. So again, it shows that the pain was more likely due to the facet joint than to the disc. So patients who had facet degeneration had greater non-recovery than patients who had disc degeneration. Of course, normal patients as well. So there was a higher risk in patients with facet degeneration. So what are things that you could see even on X-ray or MRI that you could actually put into the patient records or even put into the file? I love taking pictures of MRI because, again, these are objective evidence. So when you're talking about facet joint arthritis, you could actually have narrowing, some instability. You could have irregularities. Look at this one with all the jagged edges. So do you think this person, if they get into a fall or a motor vehicle collision or some type of trauma, that they're going to have more pain because they have more arthritis to the area? So it's really important to also look on the MRI and look for different things that you may see that are clinical indications of facet pathology. Here's a good example of edema. Do you see all that white stuff in there? So that's facet edema. And those are joint effusion. And those are all things, again, indicative more of acute joint pathology. You can look at, again, just I talked about before, facet fluid in the joints. You can look at synovial cysts. You can look at intercapsular spinous fluid, so you can see the intercapsular areas. And again, facet hypertrophy, you could see and say, well, that has a higher risk of problems. So again, if this one's nice and smooth, look how jagged this one is. That's like two pieces of sandpaper or glass rubbing together. Of course, that's going to cause problems. And also vacuum phenomena. So these are things you could see CT, MRI, that are important to try and put into the records and to explain to the patient as well. The upper cervical spine also has grades of arthritic rating. So again, this is more of like a CT scan you would look for it on. Sometimes you could see it on MRI as well, but you want to go ahead and look at those and say, wow, look at the degeneration, arthritis. Again, these are all things real to the patient and true to the patient. So it's important to embrace these, not just focus only on things that may or may not be acute pathology. And whenever you're doing the impairment rating, this is a worksheet that you use. So in the seminar I'm going to do next year, basically everyone's going to get all the worksheets, and I'm going to take them step by step through the process and go through the impairment rating so they know how to fill out the worksheets. But each body part, each section has a worksheet. So what you do is you fill this worksheet out. So this is one for the spine, so cervical, lumbar, and pelvis. You have the diagnosis. So what you do is you could look on there and say, okay, that's facet pathology. You then look and you see the class of the diagnosis. Remember from the example we did earlier that it's class 1. But again, you use the table to determine the class. Then you have the grade modifiers. So for the functional history, physical examination, and clinical studies. So you always start off in the middle. So you start off on 2. So if it winds up that it's going down and it's 1 or 0, then you subtract that and you sort of make adjustments for it. So this is the adjustment grade. So if they have a significant pathology with a lot of functional history, physical examination, clinical findings, it could be 2. And then you just change the rating by whatever factor is of 2. If it's not that bad, and maybe they still have the impairment rating, but they're functionally okay, and it looks like that they had the problem, they'll still have problems, but they're going to have some better chance of long-term issues or less issues, then you're going to go down to the 2. So this allows for some movement depending on the patient's condition. At the end, then you just put the whole person impairment rating here, and you put the, sorry about that. And you go ahead and you put the total rating down here. So when you submit this in with your report and say they have a 5% impairment rating, this is great because somebody could follow your work. And just like math, you want to be able to follow the work and they say, okay, I see where they came up with that rating. If you just guess and say, I came up with a 6% rating, that's not going to be very credible. So there was a case that I dealt with, and basically it was a 1% permanent impairment rating, explained how everything happened and how I came up with the impairment rating. And the jury said, wow, that's really credible, and had a good favorable outcome. There's another one where the orthopedic did the rating and he just guessed. It was almost the exact same type of condition, and he guessed at 13%. And when he guessed at 13%, I didn't discuss anything about impairment, but the jury came back and basically said that didn't seem reasonable. So a 1% valid true impairment rating is much better than a 13% fabricated made up impairment rating, because the jury is going to see that through that. So it's important to be credible and a voice of reason. And so that gets into the next section which is deposition and trial. So these are some things very quickly I'm going to go over as far as some tips over the years to be able to help you navigate through some of the depots and some of the trial stuff that you're going to deal with. So number one is, if it doesn't make sense, it's not true. So again, the jury is going to have a bias, and just be the voice of reason. Don't be an advocate. Don't go out on a limb. If you don't agree with something, say, I don't agree with it. And, but don't be an advocate. Just try and be a recorder of fact and very truthful and very credible. You want to be someone that the jury would say, man, that seems like a good doctor that I would go to myself. If you seem too much like an advocate or more of bias towards the patient, they're going to see that and not take your testimony very credible. So it's important. If it doesn't make sense, it's not true. So number one, prepare. Have your CV, training, study, guidelines, experience, know your stuff. Really take a lot of time and effort to really focus on what you do and get the advanced certifications, the training. Every year I try and get one certification, and just really focus on becoming the best you could be. Number two is the treatment, testing, and diagnosis. Understand it, know it. When you're going into a depot, when you're going into a trial, it's really important to study the file really well. Because if you know your stuff, but if you don't prepare for it, then that could be an issue. And it's important to also treat the patient as if this wasn't an accident. What's a normal protocol for a patient if they're, still having symptoms, if they're having radicular pain? What's a normal pathology for that? Or what's a normal treatment protocol? Are they having radiating symptoms? You can't just do a nerve conduction test on every single patient. Or a lot of times you'll see in the notes, it says patients have radicular symptoms, but yet it's more shoulder pain and not true radicular pain down into the arm. So many times we get into habit and just maybe up diagnosis or up code, and that's not appropriate. Later on, that could be a problem. Know the impairment. What's the structural damage? Be able to explain what the structural damage is. What's the disability? Why can't they work? Well, they lost a finger and they're a soccer player. Well, that's not much disability. Well, if they're a concert pianist or a typist, that could be significant disability. So know what the patient does if there's going to be long disability to say, well, they couldn't work because of this. Lost income, future care, make sure that, documentation, make sure that if there's anything that's needed, that you provide the proper documentation for it as well. It's important to review the facts of the case and demonstrable evidence, because you want to look at the MRIs. You want to be able to come in there and again be the voice of reason and be certain about what you're testifying to. Be prepared for the standard questions and case-specific questions. Are you being called more of an expert witness or treating witness? Know why you do what you do. Why do adjustments work? Why did we do electrical stim? Why did we do strengthening? Why do we do physical therapy and rehab? What does it do physiologically? What does it do? And be able to explain that to a jury. Your fees, what do you charge and why do you charge them? And the time. Make sure to be early and plan for some overtime. So the last thing you want to be is on a stand or in a depot and you allocate it for an hour and it's taking you a lot longer, so it's important to plan. It's also important to have good communication. How long do you expect me to be on the stand, or how long do you expect me to be doing this deposition, so you can plan accordingly with your staff, because you still have to see patients. And so make sure to plan it in a time that you could allocate enough time to be able to travel, get there, testify, and come back. Another thing, you don't want to just really be running into court. You want to make sure that you're having enough time, that you're coming in nice and calm and collective, and that you're not just running in and be all adrenaline filled. Preparation, and it's all about jury perception, dress and appearance. You want to be as professional as possible. You also want to know that on your website marketing material, those are all things that they're going to pull up to try and go over with you. So if you have a lot of controversial stuff, they're going to pull that up. Reputation, keep it real. So again, from a jury standpoint, you want to make sure that they look at you and they say, wow, this is a doctor I would like to go to myself. And lastly is execution. So keep it simple, really, don't get too complicated. It is important, although I went into some more technical things today. Went into jury, I have models and we sit there and we actually talk about things a little bit more simply. So it's important to keep it simple. It's important to also talk clearly, because when you're talking to the jury, you want to make contact with them, talk slow, look at them as far as when they're nodding, make good eye contact with the jury. And again, like I said before, you also want to be the voice of reason. You want to make also definitive statements, and by this time, when you're in court and you've reviewed the file and you've gone that far, your opinion should be pretty solid. You don't want to get in a situation where, you're flip-flopping back and forth. Well, maybe it could be, maybe it couldn't be. I don't really know about this. Make definitive statements if it's available, but also if it's something that you don't know, just say, I don't know it, because you don't want to go down a path of making a statement that's not true, and then later on them crossing you about that as well. So be definitive in your statements, but also be confident and make sure that you are saying them with authority. Stay calm. Sometimes they'll make questions or say things to try and make you sort of act out of character or seem to the jury that you're illogical or that you're just an advocate there just for money. So, stay calm no matter what they say. And listen to the questions appropriately, because sometimes they could ask you a question, and if you don't understand it, you answer it wrong. So sometimes the questions could be pretty detailed. Don't be afraid to say, I don't understand that. Can you repeat that? Or can you rephrase that in a different way? So those are very common things, but listen to the question and make sure that you're answering the question as appropriately as possible. And also don't go off into long tangents, because sometimes that will happen where you're just going off and what was the question? So really stay focused on the question. And quit taking it personal. For a lot of this, it is something where it's personal, because you have a lot of time and you feel things are really the way you want it to be. So what you have to do is quit taking it personal, that just do the best you can, be as honest as you can, and really be straightforward with your statements. And then the results will be the results. So, but, really your influence should not be, or it shouldn't be what the jury awards or the way the verdict is. It should be more or less as a recorder of fact. And one thing I always say too is that a good expert doesn't make anyone happy. So a lot of times if you are an expert, it could be for plaintiff or defense. If the plaintiff isn't happy and defense isn't happy, but you're in the middle, that's probably the right place to be. So don't try and make people happy. Just record what you know is true, and everything will work out in the end. But many times it is very difficult sometimes in these type of situations not to take things personal, but you shouldn't take things personal. And lastly, so we are opening up for the Academy healthcare benefits. So if you are looking about healthcare, the Academy has group health insurance, and you can go to academydoctors.com. And as I stated earlier, that I will be offering these seminars for impairment ratings, concussion, and facet pathology, 15 hours each, starting in the spring. And it'll be injuryuniversity.com is where you can find more information about that. And I think now we talked, Ken, about opening up for questions, right? Can you hear me, Ken? Let's see. Would you guys have any questions?
Yes, hang on just a second. Sorry. Can you hear me now, Chris?
I can hear you.
Okay, great. Sorry. Yeah, there actually were some questions that came in through chat while you were presenting. I'm going to read them out if you haven't seen them yet. The first question was, aside from seeing the motion of the facets, what are the advantages of the motion X-ray versus a standard flexion extension?
So you get to see in the whole dynamic range of motion. So you can see different things dynamically, also less radiation exposure because of the fact that it's a video fluoroscopy rather than a true X-ray. So, you can see it through the entire range of motion, even with the hands, with the ankles. You can see things a little bit different. In the shoulders, sometimes you'll see the shoulders pop in and out. So basically, because you get to see it through the entire range of motion dynamically, not just one static film.
Okay. Who else has a question, either in the room or online? You can send it in through chat or raise your hand, and looks like, oh, now we have someone who is both in the room and online. Come on, you got to throw us a question, Dr. David.
I'm just trying to see the question.
Well, that's quite a presentation. I'm glad. I think we have recorded this. Hopefully the recording will be successful, and we'll try to make that available for people to review. I know I'm going to go back and review this thing from the beginning. Does anyone else have anything else for Allison? Come on up and hit the mic, and I'll repeat it just in case it's not going through.
I'm not 100% sure I turned my mic on. There we go.
Dr. Connelly, can you hear me? No.
He's not acting like he can hear you. I'll repeat your question. This is Dr. Allison Jancic. Go ahead. What's your question?
So my question was, I gone to actually one of your seminars talking about VMA, and so I'm wondering if he works with VMA and the ratings that they kind of provide as, the radiologists, they also do their own assessments and everything. Has he done some work with that? How would he use that in comparison with, for instance, what he's getting from, I know he does imaging and stuff in his office, but, does he work with that at all? Does he have any advice about that?
Oh, I guess I'll
So was the question about VMA?
the question was kind of a compare and contrast of what you've been talking about versus what AHI offers with their VMA product.
Yeah, and it definitely is a good tool. And, I like the dynamic motion X-ray a little bit better because of the fact you see different ranges of motion like oblique flexion. Typically with the VMA, you're only going to do flexion extension, which, you really can miss a lot of the facet pathology. But then you want to go ahead and, again, it's a tool. So sometimes you can see ligamentous instability, but then you have to match that with some of the symptoms as well. So sometimes, particularly with an older patient, you have to match what's something that is acutely related to their symptoms and what's something that may be a normal degenerative finding as well. So, but VMA is great because of the fact it goes flexion extension. It could show the ligamentous instability. The only problem is you're only seeing one range of motion, flexion extension. And you're going to miss a lot of the facet capsular ligaments. Also, you're going to miss a lot of the upper cervical. So people forget that really when you talk about auto injuries, and I hate to use the term whiplash because really whiplash is really a misnomer, but when you talk about these type of injuries, the upper cervical has a lot of trauma and a lot of force. So a lot of the pain and problems are really from the upper cervical problems with the ligaments, and they don't have discs. So a lot of theirs is the ligaments and the facet joints and the joints up in the upper cervical area. So I like what AHI does, but also you're going to miss some of the upper cervical component of the patient's pain. So again, it's one piece of the tool. I do think AHI has a lot of benefit, but also you have to be able to say, look, if it's negative, but the patient still has suboccipital headaches, and they say, you know, different pathology more related to the upper cervical spine, you're probably not going to see a whole lot because of the fact that they're not going to evaluate the upper cervical spine like you would with the DMX machine.
And is that also same with so they give you like a disability report and things like that? So would you just use that as a, just part of the evidence, and then you would add it in and just not take it as, your only way of explaining it?
Yeah. So, and there's never just one. So typically you want to do the physical examination with the patient's symptoms with the diagnostic testing. And that's why I like the AMA Guides 6th edition, because they deal with the functional history, the clinical findings, and also the exam findings. So when you take all three of those together, it gives you more clinical diagnosis. So a patient may, on say VMA, they may have some signs of instability, but they say, doc, I have no neck pain at all. I don't really have any functional exam, and you do a functional exam on them, they don't hurt, so you want to rule out incidental pathology that you may find on imaging along with the patient's symptoms and clinical findings as well, and that's, even we did a case a couple of weeks ago where the patient had a fractured hand. They went to the orthopedic put them in a cast, everything was great, but then they still had pain after the cast was removed. The orthopedic did another x-ray. When the x-ray they said the fracture healed. So they came here, so we did the motion x-ray on the hand. It turned out that on static film, it looked like it was okay, but once you move it back and forth, you actually see that actually it was still fractured. So then the orthopedic was like, oh, they don't know what they're talking about, they're chiropractors, and basically said, but I'll send you for an MRI. And the MRI said it was an unresolved fracture that they're probably going to, and now they're going to need a screw put in. But it's something where the motion x-ray did detect, because when we moved it, you could actually see that during motion, the fracture was unhealed. And then later on, when we referred to the MRI confirmed that. Now they're going to go back in and they're actually going to have a screw put in so that way that fracture could heal. But particularly in the small joints of the hand and the feet, sometimes you will see that.
All right, yeah. Does anyone else have any other questions? Thank you for that one.
When you talked about testing the facet ligaments, the capsules, you said axial loading and a test like Kemp's in the low back. Is that what you're talking about?
So, and really when you talk about the ODG guidelines, they give a good synopsis on facet syndrome. So you'd have axial pain, axial loading or the loading of the facet joint, and then non-radicular component. So basically what I like to do is I do oblique flexion like this, and I load. And a lot of times the patients, if they report, doc, man, it kills me right there. And it's almost like a jerk reaction where they want to come back. So if they have pain right down in that area, then that could be a tear. Also the upper cervical as well. So if it hurts, that's a good area to do the x-ray during that motion, and you can look at the stability of the joint. So that's why it's more referred to as functional radiography, because you're doing it in the area that hurts as far as pain is concerned. And even with the hand, when I did the hand, basically I said, well, wait, does it hurt? Well, it hurts this way. Okay, well then I move it in that way, and you can see that it's non-union. So then that's where they wound up going for the MRI to show it was still a non-union fracture. So static films can sometimes look deceiving, but when you do the motion x-ray or functional x-ray, you can see it in a different realm.
Chris, do you see that question that popped up from Dr. Joe Hans?
Let's see.
Question was,
which category would herniated disc be considered, right? Okay, so, well, is it a bulging disc, herniated disc? Is it cervical? So the AMA Guides has a whole sort of a table on herniated disc and bulging disc, and if there's radicular component, surgery, EMG, things like that. So a classic disc herniation, there's not really one thing to say a disc herniation is this. They have a whole category of disc herniations. So it depends also, is there nerve involvement? Did they need surgery? How many levels was it? So you need, my impairment rating seminar will walk through that process, but they have, I would say even in lumbar spine, they have, 4 different sections on that. So it is something where, it depends on the severity of the disc pathology and also the symptoms. What if it's compressing the thecal sac? The thecal sac, really, they don't mention anything about thecal sac. So that doesn't really matter as much. So even as far as a disc herniation is concerned, you have to really look at the film and see it's a herniation, particularly as I pointed out earlier, there are many radiologists that sort of overread. So you want to make sure that, it's credible, but also you want to look at the patient's symptoms as well. Most impairment ratings, like I do for disc herniations, are surgical ones. So if they had radicular complaints and they had an epidural and they had a solid disc herniation and they still maybe have occasional symptoms, that would qualify. Or if they have 1 or 2 level fusion, that would be an impairment rating, or a discectomy, things like that. But if it's just maybe some low-grade lower back pain with a bulging disc that's pressing on the thecal sac or herniated disc, then that's something where that wouldn't qualify for an impairment rating. So you have to have some other clinical symptoms, not just a herniated or bulging disc. There would have to be some radicular component too.
When is a good time to send somebody for an impairment rating?
So that's a great question. And actually, I should have mentioned that in the seminar. So they have to be at maximum medical improvement. One of the problems I have with some of the VMA studies is that they do it like too early. So sometimes you'll see people do it like that. They'll try and send them the first visit, or even with DMX, sometimes I'll see, because I'm an expert in some cases, especially I've done some in Florida and other places in Georgia, where they do it the first visit. And when they do it the first visit, one, they're not at MMI, so they don't qualify for an impairment rating. But also, if you really think about it, there's a lot of ligament damage that's going to cause instability. There's a lot of muscle spasm. So typically those patients, when they first come in, they're like, "Doc, I can't move my neck at all." They're really locked up, because when you tear that ligament so violently, those muscles are going to go into spasm. When those muscles go into spasm, they're not going to be able to move for a couple of weeks. So even the DMX, we wouldn't do it on a patient until after about 6 to 12 weeks. So the DMX or Motion X or VMA would be good to do, around 6 to 12 weeks. As far as for an impairment rating, they have to reach maximum medical improvement, which is basically that you don't anticipate them getting better anytime soon, which is more likely than not for the rest of their life. So there's something that would be permanent, meaning the rest of their life. But you could also expect that over the next year, it's not going to improve any.
All right, I'm looking around the room. I'm not seeing any more questions, but we still have a few minutes. So if anyone else wants to take advantage of this resource, please hop up. Anybody else on chat? It looks like you have satisfied everybody's thirst for knowledge. Dr.
Thank
Chris,
you
thank
for
you very
having
much.
me. Thank you for having me.